I slightly introduced myself earlier. My name is Mackenzie Jones. I'm the program manager for the Montana Disability and Health Program, which is housed within the Department of Public Health and Human Services. And before I introduce our next speaker, one of our disability advisors who's here with us today wanted to make a comment about something that was said earlier, just to continuing sharing. So I wanted to give her that opportunity. So I'm going to introduce Kelly Murray. And Kelly, if you want to say what you were hoping to say.
Well, I'm Kelly Murray, and what I wanted to share was I was really upset when I have Medicaid and Medicare, and my dentist didn't accept it, and I was really upset. And I went to the state, and I wrote a letter. I told the state how I felt about how my dentist was taking advantage of me because I have a disability. So I stand up for myself, and I went and I read the letter to the state. Now my dentist takes my Medicare because I stood up for myself.
Thank you, Kelly. So we are now introducing Tom Quade. And Tom, let's see. Oh no, I only had a little bit that I was going to say. So Tom has been deeply engaged in public health for more than 25 years. Upon his return from U.S. Peace Corps service in the Kingdom of Nepal, Tom identified his life's purpose of a career in public health, specifically in working to remove barriers to the achievement of health for all people. Tom is currently with Special Olympics International, where he serves as the Senior Director of Health for the North American region, including the US, Canada, and the Caribbean. His mission remains as it has been throughout the pursuit of health equity, as it has been throughout the pursuit of health equity for those who experience disproportionate system, institutional, and societal barriers in their pursuit of optimal health and well-being. Today, this afternoon, Tom will be giving a presentation on inclusive health strategies to strengthen community partnerships. Tom, welcome to the stage.
Good afternoon, everybody. I'm glad to go after lunch and not before lunch. That's never the enviable spot, but I'm not so sure that it's a good idea to follow somebody who's had a TED Talk, but because I'm not that engaging. I'll do my best, however. Just a little bit, let me give you a little bit more, just so that you understand my frame of reference for this conversation. And I really want it to be a conversation. I'm going to ask some questions and really hope that folks will share some responses. As was said, I've been in public health for quite some time. I'm actually very new, relatively speaking, very new to Special Olympics. Most folks that I encounter involved in Special Olympics, even at Special Olympics International, have come up through the system and have 15, 20, 30 years in Special Olympics. I've got about a year and a half. So prior to that is really what shaped a lot of what this presentation is. I was in local governmental public health. I was a county health commissioner for probably the 5-6 years prior to coming to Special Olympics, and was involved in various levels of local governmental public health prior to that. Started off as an epidemiologist doing community health assessments and so forth in the last millennium. So, yeah, so I have a background in counseling psychology, and worked with families who had one or more children or adult children living at home who were living with developmental disabilities and at risk of being placed out of the home. I left that after about 5 or 6 years to join the Peace Corps. That's when I learned about public health, or the lack thereof, and recognized all the ways in which we sort of take for granted the access to health, the access to things that help us be healthy, at least that I was, in my privilege, able to experience growing up, and realize that not everybody has that. that's what got me back into school and getting my master's of public health. Worked briefly in the World Health Organization in Kosovo at the end of that crisis. And then when my mother passed away, she was a primary caregiver for my older sister who lives with developmental disabilities, who has frankly, obviously shaped a lot of what I've done in my life. And so I came home to take care of her and become her legal guardian, a primary caregiver, and experienced different barriers to health and healthcare that I had ever experienced before, since I was responsible for somebody else's health and healthcare. So that's my frame of reference as I go through this. So just a little bit about this session here. We're going to talk about some of the things we've talked about already, but we're going to try to define them a little bit better and a little more operationally, just as a context by which we'll talk about community partners, because it really, for me anyway, it's a very easy connect. But I need to start at the very beginning, and I'm not going to sing any never mind. Yeah, so I'd like to hear from you. I mean, we've used the word health equity a bit. I don't think we've actually defined it yet, and I was wondering if somebody in the audience wants to take a shot. There's no right answer. There's a lot of different ways that we talk about health equity, and there's some, I think, fairly common ways that we represent it graphically, standing on boxes, looking over fences at baseball games and things like that. But could anybody sort of share their definition when they talk about health equity, what they mean? Yeah. Equal access to care. Okay. What can you go a little bit further? What makes things equal in terms of that access to care?
Acceptance of like certain demographics of people stuck with Medicaid.
Mm-hmm.
So they can only go to a provider that takes Medicaid. So maybe broadening those horizons.
Uh-huh.
Also, no access to naturopathic doctors if
Yeah.
you choose.
Okay.
So stuck in that Western medicine.
Mm-hmm.
Physical access issues I'm experiencing a lot with the hospital system in Kalispell, where folks are beautiful curb cut there, but there's a big divot in the asphalt right in front of it, or things like the ground rising or
Mm-hmm.
making a berm that a person who uses a wheelchair can't navigate to even access the clinic. So many different, in my little corner of the world, again, transportation is a huge issue. And we do have accessible transportation, but it is not on demand. So when it's call ahead, we've got to make sure this specific vehicle picks you up because it has a lift.
Mm-hmm.
And then those folks getting left behind if they're not promptly outside the clinic when the bus arrives, even if they've asked for it at 4, and the bus came at 3:30 and then left them there at the clinic.
Gotcha.
So those are
Yeah.
a few things.
Those are great things, because that actually sort of ties in to where I'm going with this. So thank you very much for setting
You're
that
welcome.
stage. Yeah. Anybody else? Yeah, in the back there, a few.
Thanks. I would just say making sure each individual has the resources they need to live a healthy lifestyle, and be able to be a contributing member of society.
Yeah. So you've taken it beyond health, access to health care to access to health and well-being. Yeah. Anyone else? Okay. Well, I'll share mine, and it's very similar, but I take one little nuanced difference, and I think of health equity not as a state that you achieve, but a pursuit that an achievement you pursue, right? I have a twin brother who's just retired as an English teacher after 30 years, and I can feel him twitching right now when I said that, health equity is. I think of it as an act. It's a verb. It's a pursuit, right? It's the act of identifying and mitigating barriers to everyone's achievement for their own optimal health. So it does mean something different to everybody, right? In terms of their own experience with health equity or lack of health equity. We clearly don't have health equity. I mean, everybody in here experiences health and accessing health, or health care and accessing health care differently from one another for any number of reasons. Can be geography, can be transportation in terms of accessibility. I mean, any number of things. Finding a provider that accepts Medicaid, right? I mean, these are all health equity issues. So the act of identifying and mitigating barriers, let's put a little finer point on this for this conversation. So it's the act of identifying and mitigating barriers to the achievement of optimal health for people with intellectual and developmental disabilities. That's going to be my frame for this. So how do we identify barriers to health? That was more of a rhetorical question. You're off the hook for that one. How do we develop strategies to mitigate them? All right, so think about both of those rhetorical questions, and what do you think I'm going for as we have this focus on inclusive health? We must intentionally engage people with lived experience. That's inclusion. We talk a lot about health equity and our pursuit of health equity, but we're not going to achieve health equity or anything close to it until we identify and listen to the people who are not experiencing health equity. Now, we've been more intentional with some populations than others. That's a good thing, but we haven't quite gotten there yet. And clearly not with people with intellectual and developmental disabilities. It's a different conversation requiring a different skill set than most folks in public health are used to, right? So we have a lot of work to do. We also talked about social, well, I don't know, have we mentioned social determinants of health, or we've talked about it, but we haven't called it that. And you're the first example on health equity where it was a social determinant of health. The comment about finding a physician or a dentist that took Medicaid, another social determinant of health. So what do folks, what does it mean to you when I say social determinants of health? Surely there's some public health folks around the room that have that use this language. Yeah.
Factors or drivers that influence health, so like transportation or where you live or access to services,
Yeah.
education, finance, housing,
Yeah.
etc.
All the non-medical things that impact our health, right? It's taking a look at our pursuit of health, either as an individual or a population, and saying it's not just about sort of biochemistry. It's not just about the act of engaging in physical activity or eating in a healthy manner. It's the stuff it's the environment in which you do all of those things. And we already just went over some examples. And all right, does everyone share the same experience with social determinants of health? Clearly not. Not any two people in the room do, frankly. I think a great number of us probably are clumped in one sort of experience, right? We have, if you have a job that has healthcare, you have, that's less of a barrier. If you have financial security, that's less of a barrier. If you have access to transportation, that's less of a barrier. If you have a higher academic achievement, then you experience things differently than folks who might not. So how would we know? How would we know that folks have a different experience with social determinants of health? You saw this answer already. Engage people with the lived experience. It's inclusion. We can't just do what we do in public health the same way and expect to reach that next population that we have not reached at all very well, right? People with intellectual and developmental disabilities have been left out of most of the conversation around health equity by public health professionals for as long as I've been doing it. Okay, Chris mentioned earlier the social model of disability. All right, so we're going to talk, and you actually had, oh no, that's your never mind, that's something else. I scribbled down some notes that I'm really trying to read my handwriting, and I can't. I should have taken a picture of the slide as opposed to just writing things down. So social model of disability. This disability is not caused by an individual's medical condition, but by the attitudes and structures of society. People are disabled by barriers in society, such as a lack of accessibility or negative attitudes. Being disabled is part of the normal spectrum of human life, and society should include disabled people. One of the, as I said, I've been with Special now for about a year and a half, and one of the things that I learned early on is through the best of intentions, a lot of the work that we do at Special Olympics is, well, we do a lot of pilot projects. We do a lot of things that we wish that the world in general would do, especially in the field of public health. But we set it up and then we keep doing it off to the side as opposed to saying, let's change the system so that we don't need to do that thing off the side. One of our best examples, and I'll talk more about Special Olympics and the health programming tomorrow in a different session, but one of the things that we do a lot in Special Olympics, and most of the state, I think virtually all of the state programs and national programs around the world do, is a program called Healthy Athletes, where we screen folks that are participating in Special Olympics. They're at an athletic event, they're at a regional game or a state game or whatever that might be, and we have different tables set up where we do screenings across a lot of different disciplines. And we've gotten pretty good at that. But what we haven't really done is to say, well, why do we have to do that? Shouldn't that be happening in the world outside? Shouldn't we be working to change the health system so that folks get their dental screening at the dentist just like I do, right? And so we run these parallel systems. And so one of the things we're trying to do is to say, this is work we're doing in health systems approach. Let's change society. Let's change the world. Let's change the environment in which we pursue our own health or the health of those that we care for, so that we don't set up some sort of specialized, non-integrative, segregated kind of service, right? So this is the reason I talked about health equity, social model of disability, and social determinants of health is because our work is right in the intersection of all of that. And so we really need to understand that this is where the work happens. If we're going to change the system in which people pursue their health, which gives them greater access to their pursuit of health, we're right in that sweet spot there. So when we talk about social determinants of health, we're doing something that I always refer to as going upstream, right? It's not where you are in terms of your health. It's the what came before that. Why is it that? Well, then why is it that? Well, then why is it that? And there's, oh gosh, there's a critical thinking terminology for that, and I'm totally blanking on it. Where you ask the 5 questions, why is that? Why is that? Root cause analysis. I'm getting old, but I'm not gone yet, right? All right, so yeah, root cause analysis. And so when we think about that, we take a look upstream at the causes of health disparities experienced with people with intellectual and developmental disabilities. They're social in nature. There are some diagnoses that carry advanced risks for certain kinds of diseases, but that's true for folks that are neurotypical. Right? We all have different genetic predispositions for different kinds of diseases. So that's not it. That's not the cause of the disparity. The cause of the disparity is the system in which we're living, and all of those points of interaction, behavior choices, of access to things that make us healthy, of making those healthy decisions easy decisions. Remember all of that? That was the big thing. We said, let's make the healthy choice the easy choice. Well, but we can't just stop there. What is it that makes it an easy choice, or probably more to the point, a less hard choice, right? Yep, just said that. So what are some of the social determinants of health for which disparities exist for people with intellectual and developmental disabilities? Someone want to share? Education level, absolutely, that could be one. Access to affordable housing, absolutely. Yeah, where we live impacts how we live. Reliable transportation. Mackenzie?
Access to employment,
Access to employment. Yeah.
purposeful employment.
Purposeful, meaningful, yes, valued, paid employment, right? Yeah, they're the same. They're the same social determinants that impact all of our ability to achieve health, but they're amplified oftentimes for folks with intellectual and developmental disabilities because they're barriers to the barriers, right? And when you consider cross-sectionality across other populations that experience health disparities, that amplifies them further, all right? It kind of begs the question, why has it taken us so long to get to this point where we recognize health disparities? We've been talking about health disparities in a variety of different ways, using different language around health disparities for, again, decades. And we're just now getting around to this. So we're here, all right? Let's not judge. Let's pick it up and move it forward. One thing I didn't see happening, I don't think, and clearly I understand that not all disabilities are visible. How many folks were looking at their table and saying, is there somebody here with a lived experience that I can maybe ask them what their experience with social determinants of health is? Okay, that may have happened. I just, just thought I'd ask the question. All right, then, so when we're talking about, yes, please, yeah.
I think one of the big social determinants is having somebody who has a shared lived experience with you that can help you access everything. And for people with disabilities, being able to access peers who share that lived experience of consistent discrimination and ableism, what it feels like to go through your day and experience so much negative attitude and low expectations. The only way you resource against that is by being with your peers who also experience that, and you come up with your tools for confronting that, for letting it go, for creating space for yourself to breathe through it, whatever it is. And so I just really want to bring that forward, that at that intersection is true oppression, true discrimination, true ableism. And I just wanted to name that, and that the words, the tools, the way of being together in the disability community is also what defines disability. It's a tremendous source of pride. It is culture, it is community, and it does come around this lack of fitting and the negative attitudes that are experienced.
Yeah, no, absolutely, absolutely. And I think that folks from a lot of other ways we chop up the population would say that exact same thing. It is. If you don't have that community of shared experience, you don't truly understand. Frankly, and again, I point to my sister and my experience with her, and not as her brother growing up, because I was just like anybody else's brother growing up. I was not taking care of my sister. I mean, stand up against the bullies, but that was about it. But yeah, unless you can share in that lived experience, it's you're on the outside looking in, and there is overt and subtle and unintentional, as well as intentional, oppression. Yeah, so just I'm way ahead on my slides. I didn't time this out very well, so I'll take a minute and digress. My sister was when my mom passed, my father started taking my sister to his doctor. And his doctor was a buddy of his, and they just, they go in, and she'd go in for her doctor's visit, and the doctor would just talk to my dad, and not even about my sister, just talk to my dad, they're buddies, and just sort of do this, very cursory sort of exam sort of thing. And I often wondered why that was. And then as my father's 94, still around, lives on his own and everything, but is no longer responsible for taking care of my sister. That's my job. And so when it became my turn to decide, who's going to be providing her health care, I shopped around and waited until we found a doctor that I don't know whether she was trained or just new or just, one of these folks that said, you know what, I'm going to talk to that person. I'm going to peek out of the corner of my eye at her brother, but just to verify responses kind of thing, because she just, didn't really know. And it's a very different thing because it is about valuing the other individual. It's about not saying, well, there's somewhat less valued, so they don't need that same interaction, and whether that's in a doctor's appointment or at the checkout at the grocery store. If we're not intentional about recognizing the value in somebody else, then we're gonna go to those implicit biases that we have of how we value people differently based on any number of things. Actually, I will also share that once I found that right doctor for my sister, as soon as that appointment was over, I said, "Are you taking new patients as well?" Because now she's my doctor. Because any doctor who will understand how to work with somebody with an intellectual developmental disability, take that time, show that respect, and really seek to first understand, make sure that the patient understands. That's the doctor I want, right? So yeah, I think I am forever thanking my sister for all of the things that she's given to me in my life. So let's ask this. Yeah, go ahead. Sorry. Yeah.
So I really like that comment that you made about like peer to peer and that social connection. I don't know what your name is, but you said that. And thinking about that as a social determinant of health, because coming from a public health background, and now I'm more working in disability inclusion, but I didn't think of social connectedness as a social determinant of health. And I think that this is like the first time that I thought about that when you said that. I have worked in the Department of Aging, and social isolation comes up a lot there. But specifically with people with disabilities, that important piece of having that connection. And I've been doing a lot of research because for like my tobacco programming that I'm also doing, we look up, what do how do you modify a program or make the program work for people with disabilities? And always what comes up is this connection, doing peer-to-peer, facilitating these groups. And I even now kind of looked over that and I was like, like these are the evidence-based things, but like hearing you say that and knowing, and then thinking about like when I do the research, it constantly comes up the importance of that connection where even when you're thinking about food or tobacco, if people are coming together, sharing an experience, being able to talk to each other and feel safe and heard, and then being more receptive to the information that's really important. So I appreciate you saying that.
Yeah. And it wraps around all of it. I mean, that social connection, in addition to just not living an isolated life, which is not healthy, it also, you're part of a group. You're part of a group experience. You're part of a societal experience, and your solutions are found there. Your advocates are found there. Yeah, that's how we're going to change those social determinants of health. That's how we're going to mitigate the barriers that they present. Okay, so back to the question of why do we need to engage with community partners when we're mitigating detrimental social determinants of health? So when we're looking for solutions in the work that we do, why do we need those community partners? Yeah. Thank you. Yeah. You're right. You're right. And we in public health, and folks are familiar with this one. We say public health is everything, right? Everything is public health. Everything we do, every experience we have, every moment of our waking and sleeping lives has something to do with public health. But the reverse isn't true. No public health person, no public health agency, no public health entity, no public health department of anything addresses all of those social determinants of health. Because if they did, we just have sort of one department of stuff, right? And we don't. We have a Department of Education, we have a Department of Transportation, we have a department of, of everything that we well, for now anyway, everything that we experience. Shouldn't have said that one. But we can't. You're right. We can't do it all. And that's a challenge, especially for public health mentality, right? We always think we can do everything, and so we always try to do everything. And we forget that we're not probably supposed to do everything. And this is another one of those ideas of inclusion is we're not the experts. We might be the experts in the thing that we do the way we've done it. We might be the experts in trying to find new ways to do the things that we've always done the way we've always done them. But we're not the experts on everybody else's experience, right? So it's that same premise of inclusion. So let me ask you this, for folks who work in ways that involve community partners, who are your community partners? Who are some of the folks outside the door where you work, or the home office where you work? Who are the folks that get paid from somebody else than you get paid for, right? Who are your community partners? Anyone? Come on, help me out. Yeah.
So actually, I came here from Fort Peck, and we don't have community partners. This is it. It's like me, my partner has a daughter with a disability,
Uh-huh.
and so they actually held a resource fair pretty recently and had people from around the state come, and we were learning that like we don't actually really have any resources or community partners over there. So we're
So you're
it.
looking.
Yeah.
There you go.
I mean, yeah, we
Yeah.
are.
Yeah.
And but it's us.
Gotcha.
So-
Gotcha.
Oh, my name is Kai.
Thank you,
Um,
Kai.
Yep.
There's in the back, there's hand up. Yeah.
Some of my community partners that I've partnered up with is like the Down Syndrome Association of Central Kentucky. So they've reached out to me because they didn't have that. The extension offices are like what I call my community partners, because in Kentucky we have 120 counties. Why, I don't know. But of those, every extension office is considered a community, especially in the rural part, a community center. So that's where we've started to partner up with them to bring people together and get all these different resources, and reaching out. Kroger, which I guess here Albertson and stuff, they've reached out. They have a high presence in Lexington because they own the football field. But they've reached out and they've become a community partner, as like for me, to supply me with different, not all the time, but different foods, and make some foods available for some of my participants.
Yeah. So sometimes we have community partners because they provide us resources that we don't otherwise have in terms of just the the hard goods.
I'm coming. Yeah. There is a second microphone. If maybe Stacey, you want to grab that one, I can watch it front.
So
you.
I have a garden through the Garden City Harvest so they're partners with me, and then I also belong to the TOPS chapter, which is Take Off Pound Sensibly, and so they're also a community partner for me to rely on helping me get ideas on how to lose weight.
Yep. Good. Yeah.
I'm Emily, and I'm with Garden City Harvest. Hi, Connie. And run the community gardens program. And so a layer of, Connie, you mentioned us as a partner of you, and our partners are like, we work with the food bank, we work with Missoula Aging Services, we've worked with Summit here in Missoula to give us feedback on our garden design and how it can be more accessible. And we also have a host of other partners, but they're so essential.
Yeah. Yeah. And so I think what I'm hearing, and I'm not from a nutrition space, okay? But I think what I'm hearing are examples of partners that kind of share that nutrition space with you, and if you're working in that nutrition area, right? I mean, they're directly tied. And so from public health, we would often find partners in other health agencies, hospitals, clinics, the federally qualified healthcare center, right? But one of the things I think we might need to appreciate need to do, and something in public health I always had to do, was to think about novel partners. Think about those folks that you would not traditionally think of when you say, who are the folks in the community that are doing the work I'm doing, and change it to say, who are the folks in the community that maybe it's where people go that I want to reach. Maybe it's the folks in the community that provide a service that's a gap that's tied to a social determinant of health that I can't provide. I'm trying to think, we had, oh gosh, back in 2017, I had the good fortune of being the president of APHA. And so one of the things that for the American Public Health Association. And so one of the things you got to do as president of APHA, got to do or had to do, I'm still trying to make sense of that one, was we would go to all of the state affiliates of APHA, right? So like the Montana Public Health Association, I don't know if it's called that or not, but we would go to probably 20 of the 54 affiliates and give a keynote address, whatever. And mine was always about novel partnerships in public health. If we're to address the social determinants of public health, and we can't do them inside the health department or with our traditional partners, who are those novel partners? And I remember that was one of the few times I actually practiced what I preached. I don't always do that. But back home where I was the health commissioner in a small county in Ohio, we had an issue with, it was a lot of issues with heroin. And so one of the things we wanted to do was to have a risk reduction program where folks would bring in dirty needles in exchange for clean needles. And this was in a community that wasn't really kind of cool with that, right, at first. And so what we needed to do was have community conversations. And I knew that if we did that from the health department, it would carry a certain flavor, maybe a certain bias. Folks would just sort of assume where we were going with this. And so the community partner that I reached out to was a respected organization in the community. A lot of the older folks in the community were belonged to it, and I figured that they were going to be good with it. And it was the League of Women Voters, right? Not a traditional public health partner, but when you think about policy change, when you think about folks that had influence in the community, the folks that had the ear of the folks that you needed to get permission from to do this, they were a fantastic partner. So they hosted a community conversation, and I mean, I think I was the only person there from the health department. I sat in the back and just let them run with it because I also didn't want it to be a public health thing because then we would be the targets of a lot of other stuff. And so they they shared it. I gave them the content and the justifications and the data and all of that. But they were our community partner. And there was another one that we used quite a lot, and it was our Chamber of Commerce. The president of our Chamber of Commerce in Marion, Ohio, was from a different political party than myself, and had very different views on people pulling themselves up by their bootstraps, and then I would say, but they need boots first, and things like that. But the conversation was, well, let's not talk about the strategy. Let's talk about the outcome. And then I backed from the outcome of saying, well, we want folks to have good jobs. We want there to be good industry in town. We want there to be, good working conditions. We want folks to be educated and trained, able to work in those things that made the community economically strong and viable. And I said, that's great, because the social determinant of health is, the more folks we have jobs that pay living wages, the healthier they're going to be. So we agreed on that, and then we just stayed laser focused on that, and we got along fine. Nobody ever understood why we were good friends, but we found that spot, and that's a community partner, right? These are we had another example of a non-traditional public health partner, and this, all right, so this is nutrition related. At our health department, we had a WIC program, and our WIC director was also very kind of innovative, and she said, well, where do people go? How do we get in front of folks that would benefit from the services we provide? Well, she was also active with the local public library. And so what we would do is once a month, we would load up a whole lot of car seats that we got through the WIC program. We'd bring them over to the library. The library would have family reading hours. We also knew that one of the best predictors of positive health in adulthood as children who can read. If you're reading by the time you're, I forget what the age is, statistically you're much more likely to be healthy, growing up. And so we partnered with them, and it was it was just a really good example of sort of outside of our space partnership. And I'm going to circle back around to that here in a second. But I think we've talked about why are they your partners. They're doing things that you can't do, right? They have experience that you don't have. They have expertise that you don't have. They have access to populations that you want access to, and so forth. I'll come back around to this. So working with new community partners. The inclusion principles we've spoken about today, they apply to partnerships as well as people, right? When we're talking about being inclusive of another individual or another group of individuals that might not be the same as we are, it's the same thing when you're talking about community partners, right? All of those things apply, right? You need to exercise humility. If I want a community partner, I'm not going to go and then tell them how they need to do something different to help me out. I'm not the expert in what they do. I need their expertise in what I do, right? We need to be flexible with a shared agenda, right? So going back to those other examples that I shared about our community partners when I was in Marion County, it wasn't, hey, this is what I want to do, and I need you as a partner to come do what I want to do the way I want to do it, because I just need that thing that you have that I don't have. That's not a partnership. We need to be flexible with the process. They may operate different than we do. When you have a community partner, they're not part of your agency. They're part of a different agency. They may have different protocols for things, different ways that they engage the community, different conversations. And this isn't a bad thing. Some people think that this is a bad thing, but partnerships are transactional. You get something, you give something. It's not a bad thing. The earlier you find out what it is that they and they find out what it is that you need, the more likely you're going to have success, because you can meet each other's needs, and that's why you have a partnership. Partnerships are also relationships, and I also happen to believe that relationships are transactional. It's a give and take, right? We're there because we benefit from it, and they're there because they benefit from it. The same thing happens in community partnerships. I think that the nuanced difference between that and that transactional relationship is the commitment. It's I'm not just going to be your partner when it's convenient to be your partner. I'm not just going to show up, or, have you show up for my meetings, and I'm not going to show up for your meetings. If I'm going to ask you to be part of my coalition, I'm going to join your board, whatever those things are. But it's follow through, right? So they really are relationships if you want them to last. I usually rail against this idea of collaboration, because when it has a nice, we use the word collaboration all the time. It used to be you couldn't get a grant unless you wrote the word collaboration in it, 50 times. But collaborations are situation specific. They're temporally limited. We're going to collaborate on this project. It's really just like a group project in school, right? You get together, you're usually assigned those different people, and you sit there and you get your project done, and then it's like, never mind, see you later, right? But when you're talking about community partners, as long as you're going to be in that community, as long as the population of that community is going to be in that community, as long as your partner is going to be in that community, you really need to have a relationship. You enter it with humility. You accept, a negotiated process, a negotiated agenda. Sometimes it's not the agenda that you wrote, but you say, wait a minute, if the population I want to be able to access health better is going to access health better, at the end of the day, I don't really care the process. If you're going to get there, if you're going to help me get there, I'm going to let you help me get there. Doesn't have to be my way. All right, so this is sort of my final question, and if you have an answer, great. If you don't, that's fine too. But are your community partners inclusive of people with intellectual and developmental disabilities in their work? Because we're sitting there having this summit because this is something that we're trying to be intentional about doing, which means it's not something that came naturally. It's not something we've always done, right? That's why we're here, is to learn different ways to do that, and the reason that we should do that. So it's probably safe to assume that many of your community partners in this work don't know it either, right? So we need to make sure that when we have that community partner in this work, that we're bringing them along in this journey towards intentional inclusion of people with intellectual disabilities, where there's really not much point. So I think that's all I had. Yeah, that's all I had. Does anybody have any questions, comments, shared stories? Yeah.
Thank you, Tom. I really enjoyed this. And also because when you look at community partners, I'm Noni Wolf, I'm from Browning. Um, and have brought our Blackfeet Inclusive Health group together. And we are basic community partners. And we're individuals who may or may not, but are willing to learn how to provide better services to people in our community who have IDD. And one of the things that I found in the year that we've been, there's 6 or 7 of us, would you say, Caitlin, that are coming together to the table every month. But we just acquired a couple of more because we have some organizations in our community that have been holding conferences for disabled folks and never thought to invite us, even though they are on our email. They get emails from us, minutes of our meetings and all of that. And after I went and attended and learned a lot, one of the things I learned is how many people in our community have traumatic brain injuries, which makes them then disabled, intellectually disabled, and how these organizations are helping them be employable. And so at our last meeting, which happened after that conference, maybe the same week, one of the major folks that I first approached came because now she saw how we were connected. And, we have partners, we have SNAP-Ed, we have our extension folks in Cut Bank. So we're actually pulling the reservation and the county together, which have traditionally operated as 2 separate entities in Glacier County. So it's growing, and it's growing kind of slow, but it's like trying to find who are our people. Let's define them so that we can be sure that they can come for services, but also understanding what those services could be. So this was really helpful to me, and it kind of makes me think a little bit out of the box for who we should be inviting. But we do have parent advocates on because we have autism in children in school, but we haven't been able to pin down a school person who works with that. So once they're not in flux, I guess we will go at it again. So it's just an interesting process, but it makes me feel good that I think we're still on the right track. So
You raise a really good point that I can't believe I didn't think to include, because it's something that I used to say all the time when I was doing those speeches, is we can't always expect folks to come to our table to eat our meal from our menu the way we cook it and expect that to be an inclusive conversation. It's about going to where they are, letting them get to learn who we are and what we do and what we can do to help them with their priority, with their agenda, with their mission. Because that's also a huge piece in building that community partner relationship. Sometimes it's, if you have the ability, go there, do them the solid before you ask for them to do you the solid, right?
This is Lindsay from the University of Kentucky, and following up with what Tom was saying, that's within Kentucky, we were a capacity building state just a short time ago, and I learned very quickly that was the sentiment was you can't get people to come to your sandbox even if you have all the fun fancy toys, right? So you have to go out and encourage them and build the connections. And the one thing I wanted to share, and the way that I was successful in doing that, was by sharing the data. We've talked, I'm not a numbers person, I'm a programmer. I like to be in the community, but I learned very quickly on that when I could go into a meeting with someone in the health field and explain how 1 in 4 Americans experience a disability, and then in our state or in our county, what does that specifically look like? And then seeing the looks on their faces when they go, oh, I didn't know that, or I've never thought about that before. And then the very next question was always, so how do I include this population? And then that's where I had them on the hook. And so learning about how that data is important and sharing those numbers and really seeing what the need is to be able to get everybody on the same page of being able, okay, now we know why, so let's figure out the how. And that's how we've developed a lot of community partnerships in our neck of the woods.
Great. Thank you. Okay, I'm not sure who's next. I don't have that.